Okay. Yeah, good afternoon, everyone. I think we should just start. Maybe other people will join us as we run. So, on behalf of I want to warmly welcome everyone to this insightful webinar tagged From Hesitancy to Clarity, Navigating Benign Prostatic Hyperplasia in General Practice. I'm sure you will also agree with me that BPH is on the rise and is actually outpacing the capacity of the few specialists to manage it. And as a result of that, we in Superior Pharmaceuticals firmly believe that general medical practitioners like yourself occupy a pivotal position in providing access to well-informed and good care for BPH patients. Hence, this seminar we are bringing up for you to actually have a specialist knowledge and skills required to address these pressing issues effectively. And with us here to do justice to this issue is no other person than Dr. Nnabugwu. Dr. Nnabugwu is an associate professor of surgery at the College of Medicine, University of Nigeria. He's also a consultant urologist at the University of Nigeria Teaching Hospital, Enugu, a fellow of the West African College of Surgeons, and he also holds a PhD in health administration and management and has over 2 decades of clinical, academic, and administrative experience. Dr. Nnabugwu is a distinguished researcher with more than 50 scholarly publications, contributing significantly to urologic oncology, lower urinary tract diseases, reconstructive urology, and healthcare management. He is also widely recognized for his excellence in medical education and surgical expertise, and he remains committed to advancing patient care, research, and training the next generation of surgeons in Nigeria and beyond. Let's welcome Dr. Nnabugwu to the house. Yeah, welcome, Doc.
Thank you very much, Mr. Victor Obunna. I'm very happy to be in your midst. Very, very happy to be in your midst. I want to thank you for this opportunity to be here. And I seize this opportunity to welcome my colleagues who are present here. We always talk about continuing medical education, a way of making ourselves better, giving ourselves updates on what is current, and keeping ourselves useful in the current practice. And so I want to thank everyone who has made our time to come here. I've noticed some people are already complaining, there's no time, what are we wasting our time here? Please, I want to crave your indulgence to please just bear with us. And this is happening because we are still in Nigeria, because beyond here, nobody will wait for any person. Once it's time, we start, the program starts. You join whenever you join. Okay, so again, welcome. I welcome everybody, and I want to thank very specially the organizers of this webinar, Superior Pharmaceuticals. I can see Victor Obunna here. Thank you for the opportunity you've given me. I also noticed Victor Ayogu entered the forum, the meeting. Thank you again. for the opportunity. So I think we'll go straight to the issue at hand, if I'm given the permission to proceed. Thank you.
Yeah, I think you should go ahead, sir.
Okay, thank you very much. My slide is visible to everyone. I want to ask those of us who are not speaking to please mute their mics so that we do not have noise in the background. Please. Dr. Ezekwe, your mic is open. Dr. Ezekwe, thank you very much, sir. Okay, so we are going to look at what has been presented from hesitancy to clarity, navigating BPH in general practice. Like has been mentioned, BPH is we have a shared role in the management of BPH. No singular individual can manage everything about BPH. You can see that as we go along. So the family physicians, the general practitioners have a role to play in the management of BPH. And so we take it from there. We're going to look at these various aspects in this period. Please, may I ask, how many minutes do I have so that it will guide how I manage my time?
Okay, he's actually supposed to, even though we've started a bit late,
yeah,
he's actually supposed to run for like an hour or thereabouts.
Okay, so in the hour, I will have 30 minutes or 40 minutes so that question and answer will take the others.
Okay, we can do 30 minutes, sir.
30 minutes. Thank you very much. That's good enough. Okay, so we take this outline in what we are going to discuss today. Again, to sincerely appreciate Superior Pharmaceuticals for their role in this webinar. Thank you very much, Superior Pharmaceuticals. And I once again welcome participants to this webinar. We all know the organ prostate. There's nothing different from the prostate we heard about in the medical school. Now, this organ is a sexual organ, as we all know. It is located at the neck of the bladder. Okay, I'll try to. Okay, it's located at the neck of the bladder, surrounding or encircling the first part of the urethra at the bladder neck. This is the prostate. It is, of course, seen only in males. Females do not have prostates. Now, generally, it is the only organ in the human body that continues to grow for the entire life of that man. It doesn't stop growing. Reasons are not clear. But this is the only organ that we know that for some reason continues to increase in size. Slowly, but yet continues to increase in size. Because of its location, it facilitates the forward thrust that occurs during emission, forward thrust of seminal fluid, of ejaculum that occurs during emission. Now, this slight dilatation within the urethra in the substance of the prostate receives secretions from the seminal vesicle, and then the spermatozoa that will come from the vas deferens. It is at this point that those things are emptied. The prostate will also add its own secretions into what has come in here. So the semen that is ejaculated by a man has mostly secretions from the prostate and from the seminal vesicle behind the prostate, not shown here. Those organs produce 90% or more of what we'll call semen. That is the seminal plasma. Testosterone that comes from the testis, spermatozoa that comes from the testis, simply come into the secretion, and the secretion provides nutrition, support, and good environment for the spermatozoa. And so, once during ejaculation, this bladder neck closes. It closes to prevent the ejaculum from going into the shorter distance into the bladder during the contractions that come at ejaculation or at orgasm. Now, once this place closes at orgasm, everything that is poured into this lumen has to find its way propulsively, distally. Nothing goes proximally. That is a major work of the prostate and the internal sphincter that is buried within the substance of the prostate. The prostate also secretes what we call PSA. That's where it is produced. And the main job of the PSA is to liquefy the ejaculum, that is the semen. The PSA does the function of liquefying that ejaculum so that it becomes more watery, facilitating the movement of spermatozoa out of that ejaculum into the female genital tract. Now, some PSA finds its way into the blood, and that is what we are seeing as PSA assay. Anything that disrupts the architecture of this prostate increases the chances that more PSA will leak into the blood and increase the quantity of PSA in the person's blood. Otherwise, just minimal PSA leaks into the blood. Now, we also remember the prostate organ is an organ, and so it is a part of the genital system, which is part of the man. More importantly, it is made up of different tissues: glandular tissue, fibromuscular tissue, and of course, the nerves, the vessels, the lymphatics, and so on. The tissues are also made of cells. For the glandular tissue, their cells we call their sinus cells. And then the fibromuscular tissue has mostly smooth muscles and some fibrous tissue or fibrous cells. Now, these cells are very important in what we are going to discuss concerning management of prostate enlargement. Quickly, prostate enlargement can be benign or malignant. We know that. I'm just saying this for the purpose of emphasis to help us with what we're going to discuss. Benign or malignant. Globally, the figures are increasing concerning incident prevalence of prostate enlargement, the benign prostate enlargement. As life expectancy is increasing, so also is BPH, the rate of BPH increasing. This study showed that between 1990 and the year 2017, there has been a tremendous increase from 24, almost 25 per 100,000 to about 32 per 100,000. Benign prostatic enlargement to us comes in three forms clinically. That's the way we represent it clinically. First is that because I have said the prostate continues to enlarge throughout a man's lifetime, it must not always give symptoms as it is enlarging. And so we have what we call asymptomatic BPH or BPE. Now, benign prostate enlargement can be replaced with benign prostate hyperplasia. We are saying essentially the same thing. Enlargement is clinically, the clinician will see an enlarged prostate that he thinks is benign. It is pathology when it has looked at the tissue that will tell us that it is hyperplasia. The cells are increasing in number and in size. Now, asymptomatic BPH means this person's prostate is enlarged, but it is not causing any symptoms, and there is no evidence that it is causing bladder outlet obstruction. We'll call it asymptomatic BPH. Symptomatic BPH means in addition to the enlargement or no enlargement, I'll come to that, the prostate is causing bladder outlet obstruction and it's presenting with symptoms. We'll call that symptomatic BPH. Then when, in addition to these symptoms or absence of it, some patients will tell you they didn't even feel any symptoms, there are complications that we know that can come from enlarging prostate. We'll call it a complicated BPH. Symptomatic non-complicated BPH can be treated by anyone who has appropriate information. When it becomes complicated, it becomes imperative that a urologist should be in charge. The complications could be bleeding, could be an acute retention. By the time it is more than once, then there is obviously need to do something else in that prostate. Bladder stones can complicate prostate enlargement. Bladder diverticulum, chronic urinary retention, renal failure in form of what we call obstructive nephropathy. Whenever any of this is present, it means the patient must have surgical intervention to take care of the problem. In the absence of any of this, it is just symptoms. The patient must not have surgical intervention. In short, the person, it is recommended that medical therapy be instituted. Except in situations of severe lower urinary tract symptoms for symptomatic, then the person can also be offered surgical treatment. So patients who will come with mild lower urinary tract symptoms or moderate lower urinary tract symptoms will not necessarily need surgical intervention. So now, to buttress increasing rates of enlargement of the prostate, this is a graph showing over the years 1990 to 2015, a steady increase in the number of persons that live with the disability, in quotes, called prostate enlargement. YLD means years lived with the disability. We are taking that the enlarging prostate is a disability. it clearly shows a progressive increase in the number of persons, and when converted to the rates of disease, there's also a steady increase in this period that was studied in this study, Launa et al. In 2021. What about Nigeria? We found out in the Southeast that in a community study that BPH is the rate of men presenting with BPH or who carry around symptoms of BPH is on the increase as age increased. In the 5th decade of life, that is 40 and above, between 40 and 50, about 10% of men who move around complained when they were asked questions that they were already having symptoms of BPH. Towards the 70th, towards the 9th decade, that is 80 to 90, up to 70% of the men we encountered in the study were already having features of BPH. Some have had treatment, some were yet to even see a doctor. Now, another study, a similar study in the Southwest by Ojewole et al. Also showed the same picture. In a study of 615 men, about 30% were already showing features of BPH. So we can see from this that about 3 in every 10 men across all ages will have features of BPH. Or about 7 in every 10 men who are above the age of 80 will have features of BPH. This will give us an idea of the burden that we are facing in even our communities in Nigeria, wherever we are practicing. Now, the most important thing that we need to do as caregivers for those who will come to us with BPH is to take this decision very early. Am I dealing with a benign prostate or am I dealing with a malignant prostate? If we miss this answer, if we get this answer wrong, disaster will happen with time. If we're able to get this answer right ab initio, we are likely to get the best outcome of what we're doing, the treatment we are giving. How do we rule out prostate cancer in any patient who has come to us with features of prostate enlargement? First, we will have to do a digital rectal examination. Please, if you cannot do a digital rectal examination, do not confidently treat a patient with symptoms you think is BPH. Please, the minimum you can offer this patient before you start treatment is to do a digital rectal examination of that person's prostate. It is crude, it's not very sensitive, but it is still very important that we do that, because for those who will come with already advanced prostate malignancy, DRE alone is very sensitive to tell you that something is not good here. So please, may we refrain from treating BPH without doing a digital rectal examination. Beyond that, we're expected to do a PSA. PSA assay will tell us that we are in a comfortable zone or we are not in a comfortable zone to treat BPH. If the PSA is beyond 4 in any man, you are worried. 4 nanograms per mil, you are worried. But that does not translate to malignancy. No, it does not. But if the PSA is below 4, your worry is very, very reduced. It still does not mean it cannot be malignancy, but that risk is very, very low. You also need to do a transrectal ultrasound scan. Abdominopelvic ultrasound scan is very insensitive in addressing, deciding between malignant and non-malignant prostate. It can give us other information about bladder outlet obstruction. But when it comes to that decision, malignant versus non-malignant prostate, what is recommended is transrectal ultrasound scan. And it is available, especially once we begin to request for it. We realize that it is very available in the vicinity where we practice. Prostate biopsy only comes in when any of these ones I've mentioned earlier suggests that there may be prostate cancer. Biopsy is not done routinely. It's only if the PSA is suspicious, or the DRE is suspicious, or the TROS is suspicious, that will then say this person will need a biopsy to confirm that we are not dealing with malignancy. Once we exclude malignancy from using the biopsy, we'll continue our treatments as benign. So that decision has to be taken and be taken very early. Now, what is the aim of medical treatment? The aim of medical treatment for BPH is to relieve the obstruction and then to improve the person's quality of life. Medical treatment does not aim to reduce the size of the prostate. That's not the aim. That's not the aim. It does not also aim to reduce the level of PSA. No, that's not the aim. Patients may come with that erroneous idea, my PSA is high, what can I do to bring it down? That is wrong. And we need to explain that the aim of using PSA is to exclude cancer, not for it to be brought down. So once it is high, what is required is biopsy to exclude cancer, not what do I give to this person to bring the PSA down. The aim of medical treatment is not to prevent future cancer. No, it does not. The aim of medical treatment is also not to prevent future enlargement. That's not the aim. If it doesn't continue to increase in size with the treatment being given, beautiful. But the aim of what you're doing will not be to prevent it from increasing in size. No. So these things have to be clear while we are embarking on medical management of an enlarged prostate. The prostate size really has nothing to do with symptoms. We know that clearly. You have somebody with very small prostate and is having very severe symptoms. And you have somebody with large prostate and the person does not have symptoms at all. And when there are no symptoms and no evidence of bladder outlet obstruction, there is no reason to treat. For as long as you're certain you're not dealing with malignant prostate, there's no reason to treat. Now, for symptom scoring, to have an idea of how severe the patient's symptoms are, you need to be aware of this chart we'll call the IPSS, International Prostate Symptom Score. This is commonly available. You should be aware, every one of us who is planning or aiming to treat enlargement of prostate, BPH, should be aware of this because this is what guides what we do. Once it is not a complicated BPH and it is symptomatic, it is this symptom score that will guide us. The score ranges from 0 to 35. And we'll have these categories: mild, moderate, severe. And I've mentioned earlier, in the absence of complications and the symptoms are mild to moderate, medical therapy is recommended. For severe symptoms, medical therapy is recommended, except where the patient's quality of life is so bad, even with the medical treatment. In that case, you recommend surgery. For all complicated prostate enlargement, there is no place for medical treatment. Now, majority of the patients, the bulk of the patients will have mild, moderate symptoms, and then some severe symptoms. It's only a handful, a few will get into complicated complicated prostate enlargement. So that tells us that there's so much that we can do, the general practitioners, the family physicians. There's so much that we can do in this field. Now, we're also guided by the quality of life. This IPSS chart usually comes with a quality of life score. By the time you're done asking the patients, how many times have you been feeling this in the last 1 month? How many times have you been urinating frequently? How many times do you wake up at night to urinate, and so on? And you have your score. The next thing is to find out how happy, delighted, unhappy, terrible that the person is. With this information, you know whether this person will even appreciate the fact that you want to treat him or not. If somebody tells you, I am urinating maybe 2 or 3 times at night, beyond that, I'm fine. Maybe once in a while, before I get to where I want to urinate, the urge has increased so much. And you ask the person, how do you feel about this? Should you live with this way the rest of your life? The person said, no problem. I'm delighted. I'm pleased with it. Such a person may not comply with drugs, even if you give the person medications, because he doesn't even think that there's anything wrong with him. This will be unlike somebody who tells you, man, I'm feeling so terrible that this thing has to stop. For that kind of person, anything you tell the person to take in the name of medication, he will take it. And when he begins to take it and he gets improvement, he will be so happy and his quality of life gets to pleased or delighted. Then you explain to him your medication is the reason why you are getting this change in quality of life. He will never deviate from that medication. He remains compliant. So these are the things that this quality of life assessment combined with this chart will help the practitioner achieve, so that you don't bother treating who doesn't look like he will appreciate your effort. You cancel the person to change his lifestyle and you move on. Now, what are the agents that we have available to us for medical therapy? You see some of these things around. Saw palmetto, we call it phytotherapy, use of leaves. And they may work, they may not work, but those who take this are usually those who still have mild symptoms. They go over the counter, buy, somebody tells them there's supplement you can take and you're fine. They go to this and they don't bother further. But I don't expect a physician, a medical doctor, to just stay on saw palmetto derivatives for treatment of prostates, benign prostate enlargement. Once they have come to us, the doctors, we should go beyond this. Use something that has documented evidence of good action. And those come under the alpha-1 selective blockers and the 5-alpha reductase inhibitors. We've moved from the non-selective blockers, prazosin. We've moved away from prazosin and other non-selective blockers to more selective blockers, the alpha-1 selective blocker, because of the side effects of those other ones, orthostatic hypotension, and so on. Now, of all of this, Tamsulosin appears to be very, very prevalent. People use it a lot and works, does the work. Alfuzosin is also there. Silodosin is also there. These are all alpha-1 selective blockers. The differences in them may just be marginal, if any. Now, the 5-alpha reductase inhibitors, Dutasteride appears to have taken over. Finasteride used to be very popular, but Dutasteride has taken over at this point. Now, the game changer appears to be the combination of this Tamsulosin and Dutasteride. I'll give us the reasons. Alpha-1 blockers, alpha-1 selective blockers, like all sympathomimetic drugs, all drugs in the autonomic field of autonomic innervation, tend to have what we call tachyphylaxis, rapid onset of action, and over time, the actions wear off. That's what we are seeing here in this study. With initial, these are all alpha-1 blockers. You notice they all have the same pattern. From baseline to the first visit to the hospital, there is a rapid improvement in symptom score from a higher IPSS to a lower IPSS. But beyond that, subsequent visits, no further significant improvement. Compare this slope to this slope. And this is for the 3 drugs or for the 3 molecules. Now, this is for alpha-1, for 5-alpha reductase inhibitors. Improvement in a particular endpoint. You notice that this gave a progressive, sustained improvement over time. Now, look at this as well. Here, this is a Kaplan-Meier analysis, Kaplan-Meier graph that tries to show survival. The survival here is absence of an acute retention. That's the survival here. So this study, here there was nothing given. You notice the slope. Below this slope are those who developed acute retention. Above this slope are those who did not develop acute retention. Let's just understand it this way. For those who didn't take any drug, this is what it was like. This is the value proportion. Now, for those who took only Tamsulosin, see this proportion developed over time an acute retention, even though they were on the drug. This proportion did not develop acute retention, even though they were on the drug. Look at Dutasteride, a 5-alpha reductase inhibitor. See its own value. Appears to give something that is more sustained over time. This gave something that over time looked as if it started dropping. More and more people started having acute retention. Here, more people had acute retention over time, but not as much as this. Now look at the combination of the 2 drugs. Combination of the 2 drugs. Very few people eventually had acute retention within the study period. most of them, up to 90% of them, did not have an acute retention within the time of study. On this, it then became important that these two drugs combined, these two drugs could be combined to give a better outcome over a long period of time. 5 alpha-1 blockers will give immediate good response, which doesn't get sustained. Dutasteride or finasteride, the 5-alpha reductase inhibitors, will give something that appears to improve over time. Combination will make use of these two qualities of these two molecules to give a more sustained outcome. So based on that, combination has come into place. And Superior Pharmaceuticals has a beautiful combination that we have used over time and we have seen to be very, very good. The Flowell Plus, over time, we have seen to be very effective. There's something I just want to show us before I conclude. In the study we did in the Southeast here, we noticed that from the responses of the men who we encountered, those who had symptoms of BPH and who had sought medical attention, 65% or more went first to the doctor. There's just a few, just about 35% of people tried other things before eventually going to the doctor or staying with what they had tried. Herbal practitioners and patent medical dealers and nurses and lab scientists and so on. Just a few of them. Majority sought attention from the doctor first. This is an eye-opener. If we're able to manage this number appropriately, they will go back to the community and let the rest of them realize that this is the way to go. There is no reason to have started trying herbs or going to the chemist, the patent medicine dealer, to try from there. If you go straight to the doctor, they know what to do and they will give you an important, they will improve the quality of life and relieve the symptoms the person is presenting with. And so I encourage all of us who are part of this webinar. They will come to us. Majority will come to us. 6 or 7 out of every 10 will come to us first. And when they come to us, may we be in the right disposition to give them the appropriate therapy that they require before they lose interest and start to seek help elsewhere. So I'll summarize. I've said it and I say it again, they will very likely consult the doctor first, very likely. So when that happens, let us be confident in taking that decision early enough. Are we dealing with BPH or are we dealing with cancer of the prostate? If we're able to take this decision early enough, it will help us a lot in what we are doing. And let's be confident with that decision so that it will be unfortunate that over time, the patient begins to feel I'm not getting better. And further evaluation elsewhere reveals that, oh, this person actually has cancer and not BPH. Okay, so once they have consulted us, we should be able to give the appropriate therapy. And that appropriate therapy will be Tamsulosin, Dutasteride combination. It is better than using alpha-1 selective alone. It is better than using 5-alpha reductase inhibitor alone. It's also a lot better than using the non-selective alpha blockers that I also see some people still give at this point. And when we have done that, we need to be guided going forwards. How do we get guided? That IPSS should be repeated every now and then to be sure that the symptoms are better. We also have to identify from the patient what they feel about their quality of life to be sure that they are having improvements in their quality of life. Objectively, we need to do what we call post-void residual urine. That is done using an abdominopelvic ultrasound scan. Abdominopelvic ultrasound will assess the volume of urine after the person had voided urine. Once the post-void is minimal, the therapy is working appropriately. If they begin to have significant post-void urine, then there is danger of renal failure, and such a person should quickly be moved for a more definitive therapy in form of surgical intervention. PSA guides us as well, because there is, like I said before, the aim of that therapy is not to prevent cancer. And there's nothing that has said that somebody who has a BPH will not, over time, in the next 5 years or thereabouts, develop cancer. Not because the BPH has become cancerous, no, but because cancer ab initio has developed. So it is important to do regular PSA even while we are treating for BPH. And when we have started any 5-alpha reductase inhibitor, beyond 4, 5, 6 months of that therapy, whatever we have as total PSA should be multiplied by a factor of 2 to have an appropriate PSA level for decision making. Because we know that 5-alpha reductase inhibitors reduce the absolute value of PSA by something close to a factor of 2 over time when it has been used for a long period. So that should also guide us in taking decision when we use PSA, when we ask for PSA during the therapy. So, thank you very much for your time. I will wait and get your comments and questions and then throw more light on areas of interest. Thank you very much.
Okay, thank you, Dr. Nnabugwu, for job well done. I think it's more or less like self-explanatory. The way you handled it, you took it down to the basics. From my own end here, I think I really enjoyed your lecture. Thank you so much. We really appreciate you, sir. And I've also seen some questions from the chat room here. The first one from Dr. Otaka Douglas. He is also asking, can you categorically make a diagnosis of a prostate that is cancerous with just only a high PSA level? That's his question. Then maybe I should just, let me read out the 3 questions on the chat. Maybe you can handle them. Maybe there's any other person who has, then maybe by show of raise of hand, we can now tell the person to come up with this question. But let me just read out the ones in the chat room first. Okay, so the first one, like I said, the first question there is asking if we can categorically make a diagnosis of a prostate that is cancerous with only a high PSA level test. That's the first question. And that question was sent in by Dr. Otaka Douglas. Then there's also this one from Dr. Collins Obinna. He is asking, depending on the quality of life assessment, to decide if the patient needs medical treatment may not be only effective in all cases, as some may be ignorant or biased even amidst mild or severe symptoms. And I'm not sure if I got that one right. That's depending on the quality of life assessment to decide if the patient needs a medical treatment may not only be effective in all cases, as some may be ignorant or biased, even in the midst of mild or severe cases. Then there's also this question from Dr. Ilea Bolos. He is also asking the effect of sex versus BPH. Then his second question is, how effective of taking these drugs individually than the combination? Yeah, I think that has been answered already from your explanations anyway. Then there's also maybe, I don't know if you can just maybe take the first two questions, Doc.
Okay, thank you very much. Quickly, high PSA is not 100% CA prostate. The higher the PSA, the higher the chances that there will be malignant prostate, but it is not 100%. That is why you must have a histology diagnosis before treating it as prostate cancer. You must have a histology diagnosis. And to get a histology diagnosis is not a difficult thing at all. So that should never, no person should be branded prostate cancer patient without a histology diagnosis. When the patient says, I don't want, that is a different thing altogether. In that case, you can have a special consent from such a patient and start your treatment.
Right, do.
And once the patient can take prostate biopsy, please biopsy the prostate to be sure of what you're dealing with. Now, quality of life as to take a decision to treat or not to treat based on quality of life. Well, that quality of life question is very simple. And I don't think somebody will be biased about how he or she feels. I don't think any person will be biased about how they feel. Okay? I don't think so. So, if you ask me, how are you feeling about this thing? I've already come to the doctor. I'll tell you that I'm not feeling well. So I know the wordings there, the English terms there may not have direct translation in our various local languages. Unhappy, pleased, and things like that may not, you won't have specific words to give you an idea of what they're saying, but you can figure it out that this person, first of all, is unhappy. Is on the other hand, if we divide it into two, left and right, he's on the left, he's not on the right. Then to grade whether the level on the right or the level on the left is a different thing altogether. Okay? Now, that should always guide us. That should always guide us. Then the other thing about sexual activity and BPH, well, the risk factors for BPH are 1, age. 2, that the person is a man. Of course, I have said that the person is a man. It doesn't happen to women. And then the person and the person is getting older. Then the person has viable testes. These are the 3 risk factors for BPH. It doesn't depend on sexual activity. No. It doesn't also depend on food. No. Then the other thing is genetics. If it runs in a family, fine. They are very likely to have it in that family. But beyond these primary risk factors, the other ones are neither here nor there. Like somebody will say metabolic syndrome is associated with BPH, obesity associated with BPH, and so on and so forth. No problem. We know all those associations. But if you go back and look at those things again, you still realize that the person is an older man. and the person may have in their family genetic makeup a risk for BPH, and the person has viable testes producing testosterone. Okay, combination therapy, yes. If you take individually Tamsulosin and Dutasteride at once, that's still combination therapy. But why will you want somebody to be taking 2 tablets at once where there is 1 tablet that contains the two molecules? So instead of prescribing each of them one after the other, go and buy this, be taking one of this, buy only one and take that has the 2 molecules. Thank you.
Okay. There's also another question there. How often should PSA be done?
If somebody, you will usually advise for screening purposes, you're not managing cancer, you're screening to be sure that you pick cancer early. In blacks, beyond the age of 45, every man should have PSA at least once a year. If there is a family history of someone who has had prostate cancer earlier, early onset prostate cancer, such a family member should have more frequent PSA, so maybe twice a year or thereabouts. Now, beyond the age of 70, it becomes the benefits doesn't look much anymore. If somebody had been screening appropriately, and as at age of 70, there has not been any reason to suspect that that person has prostate cancer, doesn't make any sense continuing to screen that person, because we know that prostate cancer grows very slowly. That even if somebody begins at the age of 70 or above to develop prostate cancer, before it becomes clinically relevant or important in that person's lifetime, something else would have taken the person.
Yeah.
So beyond 70, for someone who had been screening well, there may be no need to continue screening. But if the person had not been doing screening, it is possible that the person had been carrying an indolent cancer all this while, and it becomes important that you screen that person. I don't know if I've answered it to your satisfaction. There are so many hands.
So many hands up. Maybe we can take them as they come. We have Melitus Taka. His hand is up. Dr. Melitus, I don't know if, can you hear us? Maybe you can ask your questions. Dr. Otaka.
Yeah, good afternoon.
Good afternoon, sir.
Hello, can you hear me?
Yes, we can.
Okay. I've even asked a few of the questions because in practical terms, it's quite difficult. I was like asking Dr. Nnabugwu the possibility of, since we know that everybody is heading towards BPA at a point in time, can we start drugs without, is it not possible to do more like a prophylaxis of those drugs without necessarily, maybe if someone gets up to 70 and 80, is it a possibility of starting the prophylaxis of this drug without necessarily waiting for possible symptoms?
Well, I will answer that immediately by saying it doesn't really make sense. Somebody is taking medication for what he doesn't have.
He may not have.
No, when you say may, that's a different thing.
Okay.
He has no symptoms and you are not treating prostate cancer. What you really need to be wary of is patient believing that as I'm taking this medication, I will not have prostate cancer.
Yeah. That's also deceptive.
That's wrong. That's wrong.
Okay.
Yeah, so it needs to be clarified that this medication does not prevent cancer.
Okay.
The only thing that we know that prevents development of prostate cancer, or the two things, will be: one, castration before puberty. Not after puberty.
Okay.
Castration before testosterone imprinting on the prostate. That is what happens at puberty. That's the only thing. The other thing is removing that prostate radically before it becomes malignant. Now, these two things are not even ethically acceptable. No, for ethical purposes, this is not recommended. Nobody has recommended that you castrate any person before the age of puberty because you are preventing prostate cancer. It is not ethically acceptable. It's also not recommended that you go and remove somebody's entire prostate radically because you want to prevent cancer. No. But we know that if the interest is in preventing cancer, there are diets, lifestyle changes that will help. Diets rich in antioxidants, tomatoes, and so on will help. Avoiding cigarettes, avoiding alcohol, avoiding all those things that we know can cause malignancy will help. Sexual intercourse or no intercourse, there's no agreement on how much that helps. Avoiding fatty meals and junk food will help. But beyond these things, if we are talking of BPH, there's no reason why you should start giving somebody alpha-1 blocker at the age of 40 because you don't want him to develop LUTs with time. You are not, it's not ethically acceptable.
Okay, I can also see Dr. Ni is an innocent.
Yes,
He's an
yes.
yeah.
Good evening. Good evening.
Yeah.
My name is Dr. Ani, actually, an innocent. I want to express my happiness in listening to my brother, Dr. Nnabugwu, somebody I've always admired. Anyway, the topic he presented today is actually so topical to general practitioners. I've actually worked in our outpatient as a medical officer for over 20 years. So, and we get to see a lot of patients with symptoms of prostate. So it's actually important that we get educated once in a while about this. So, but Dr. Nnabugwu, I need to actually ask you a few questions. I get these questions a lot. Why do we have an epidemic of BPH now? Of course, you talked about age being an issue, but people have always aged. In fact, my parents lived longer than people are living now, and it wasn't actually a problem in their time. So why does it seem that we have more people with prostate now? Is it our diet? Is it our lifestyle or whatever? Then you talked about the size of the prostate not being a problem. I mean, not being what initiates the symptoms we see. I've always thought, frankly speaking, that as the prostate enlarges, they tend to actually exert a lot of pressure and cause a lot of symptoms. And I've always thought that one of the drugs in the combination, that the Dutasteride and the Tamsulosin, one of them actually shrinks the prostate. Maybe I must have been advising my patients wrongly, but you may need to throw a little light on that. Is there any relationship between libido and the BPH? Because I get that a lot, people present and with a lot of erectile problems, and they think it's due to their prostate. Then, when should we refer to urology clinics, to the surgeons? You talked about using post void volume and so on, from the ultrasound. I think it's about 200 mils or so is the cutoff. You mean to tell us the cutoff? Then I've always thought that when somebody's PSA is above 4 nanograms per mil, we refer. In fact, we don't actually think that maybe it has become cancerous and is now producing more of the antigens and so on. So what should we use really as a marker for our referral? Is it the post-void volume or the PSA, or is it the general feeling of the patient? Thank you so much. I hope one day maybe you may actually incorporate us into some of those studies you are doing and so on. Thank you.
Thank you, sir, Dr. Ali. Thank you very much. I'm happy to hear your voice here.
Thank you.
And meanwhile, congratulations. I've not had to see you to tell you congratulations.
Thank you. Thank you.
Yeah, your questions are very, very key questions. So I'll quickly run through them. When we are younger, we may not really have known what people were going through. You're knowing now because you have come of age. But what is important is that more people get to old age now than then. And if we say that in every 10 people that get to the age of 70, that 7 of them will have features of BPH. If only 2 people got to the age of 70, the 2 may not have the features of BPH. And it will look as if this is wonderful. We don't suffer this problem in our environment. But it's not really so. So 2 things, we are aging more. We may not be getting to 100, or we may not be getting to 90, but many more people cross the age of 60 than 20 years ago. And that increases the risk that many more people will come present with features of BPH. So it's the burden is there. Yes, the burden is there. I agree with you, but it's essentially due to the fact that many more people get to old age. It's not a malignancy, so it hasn't been attributed to any of those risk factors of malignancy for now. It's a benign thing, and over time, virtually everybody's prostate grows with time. Postmortem studies have shown that people who die of so many other things still have hyperplasia in their prostate. And it wasn't a problem that was reported clinically when they were alive. Okay, so size of the prostate, you'll be surprised that many people carry large prostates and they're not having symptoms, bothersome symptoms. Many of them will end with symptoms of maybe having to wake up several times at night to pee or during the day to pee. And they readjust with that. They slowly stop taking so much fluid. If you notice many of our elderly people in the past, I don't know, they don't take much fluid. Many of them will take water only when they have eaten.
They avoid water.
They avoid water. The reason why they avoid water is not that they don't like water. It's because they have learned over time to manage this urinary problem, which has just ended at the level of storage symptoms. And if it's just storage symptoms, they urinate more frequently, but when they urinate, it flows. They gradually reduce the water they take. The one that bothers them so much is when they now want to urinate and it is not flowing as freely as they want it to flow. They are not comfortable with that. So that lifestyle change of reducing water may be how people endure enlarging prostate without really bothering so much. But we know that small prostates can give so much problem Now, I'll quickly get to the cell lines that are there I mentioned at the beginning. Here, beyond the smooth muscles, it is fibromuscular tissue. There's also fibrous tissue. If that prostate has so much of the fibrous tissue, it will give so much problem, even with the small size. And these are the people that even when you're using medical therapy, it looks as if nothing appears to work for them because the medicines will not work on fibrous tissue. The 5-alpha reductase inhibitors work on their sinus cells, while the alpha-1 blockers will work on the smooth muscle cells. There's nothing that works on the fibrous tissue. Nothing. So if that prostate contains mostly fibrous tissue, the size will not determine what it does. If it contains mostly muscle tissue, even though it is big, it will still be soft and supple that every contraction of the bladder pushes the bladder neck open enough for the person to void. So these are the reasons why size and symptoms do not correlate. And many studies have proven that. 5-alpha reductase inhibitors work on the glandular cells to deprive them of testosterone. It does not. Over time, there may be minimal decrease in size, but this does not translate to anything meaningful. Does not. Part of the reason why it appears that the 5-alpha reductase inhibitors may reduce the size is because they reduce the vascularity of that gland. And reducing vascularity of the gland gives that wrong impression that it may reduce the size. But we do not aim to reduce size using medication. We don't. And so when people talk about it, we just ignore it and move on, because we know that for as long as you are alive, you're getting older and you're still exposed to your testosterone, the prostate will gradually continue to increase. So 5-alpha reductase and shrinking, neither here nor there. Libido and erectile dysfunction in those who have LUTs. Generally, every man's ego and self-esteem begins to drop once there are urinary symptoms. Imagine having to interrupt a sexual advancement to go and pee, and you do that over and over. It reduces the person's self-esteem, and that's what primarily affects libido and erection. The sense of poor quality of life. So that association is there. But what usually happens is, because of that association, is even being recommended now that those you put on medical therapy, you can also add very low dose of IIE, or let me get the appropriate acronym now. Very low dose of drugs like sildenafil, tadalafil on daily basis with the medical therapy for LUTs. There are studies now assessing that and coming up with results that quality of life is a lot better. While the medical therapy for LUTs take care of the LUTs, the erectogenic drugs take care of the erection issues, and the patients generally report better quality of life with that combination. So that association is not because the enlarging prostate will go and destroy nerves or destroy the vascular system or give an organic reason why they do not have erection. No, it's mostly because of the psychogenic component of the fact that there's something wrong with urination, and to them, something wrong with the external genitalia. And mind you, many of them will say it is the LUTs are due to infection, sexually transmitted infection. And that association kills the person's morale straight away. Okay, so the post-void residual, many people have mentioned a number of things, 150, 100, 50 mils after voiding. So 200 is on the high side. I wouldn't want to get to level of 200. By the time we're having something beyond 100 mils post-void, that person is retaining. And more importantly, when that person was not retaining at the beginning of that therapy. And over time, it now becomes obvious that residual urine has come. I think that trend means the person should have something more definitive instead of the medical therapy. Thank you.
Okay, there's also Dr. Olawale Oni. His hand has been off for some time. Dr. Olawale, are you there? Are you still there?
No, thank you very much, Prof. Can you hear me, please?
Yes, we can hear you, sir.
Oh, thank you, sir. So, though, sir, I want to ask, because I've listened to you very well, and I'm much more motivated. We have been current rate of people greater than 65 years now that will now come to we general medical practitioners that where since they are getting older, and can there be a preventive surgery to remove this prostate so that the fear of having the BPH and prostate cancer will be removed? So most of them will just come that where some of them will prefer to have prostatectomy done. Some of them say, okay, they prefer prostatectomy done, that this organ are no more useful for them. So I don't know whether you can say more on that. Number two question is this. You talk much on fibroid tissues, and you said the combined, the Dutasteride and alpha 5 alpha dosage inhibitor and does not work probably on fibroid tissue. So there is also a growing rate of which I try to understand on nutritional factor and the diet regarding the prostate enlargement. There was this particular species of cassava. It's usually purple in color like this. I try to investigate a little bit those in the villages. I've seen people living up to the age of 110 years, these years, 100. I say, okay, and they don't have this symptom of this BPH that we are talking about. So that they are constantly taking, even frying this species of cassava. They are trying to nick into it. I don't know whether you have come I have come abroad about research regarding this. My last question is regarding the issue of any research. I just want to clear the issue about the more you ejaculate, the less the prostate enlargement. That people are usually saying, you read online, that at least 21 ejaculation per month. So, and the last one, regarding this Flowell Plus, I don't know whether this complaint is in thinking regarding the long-acting effect of this drug, whereby because we discovered patient compliance in taking the drug is also very high. That, doctor, I can't be taking this drug every day. Oh, I took it last week, and I took for 2 or 3 days, I stopped it. So the patient compliance, I don't know whether there is a research being going on whereby it's going to be in like an injectable one twice in a year, or the drug. I know the drug cannot work twice in a year, but the injectable one. Thank you very much, sir.
Thank you. Well, I don't know if somebody does not take tablets, the person will prefer injectables. I don't know, or he wants depot injections that will last there for months. Well, okay, now, with respect to prevention of BPH by doing surgery, I said it before, and I'll say it again. Removing the entire prostate because you want to prevent BPH has risks. If you listen to, there was some months ago, somebody showed in the media that robotic radical prostatectomy has come to Nigeria. Now, radical prostatectomy is the removal of the entire prostate because you want to prevent BPH from occurring. Well, it doesn't make sense because the risks associated with that radical prostatectomy is so high for something that will not happen to everybody. So if somebody would develop a BPH, once it defies medical therapy, or for that person who doesn't want medication, TURP is a peaceful procedure that can be offered these patients, and he's home. No need for medications, no consequences, and he's fine. Stay in the hospital may just be a day or two after the procedure, and he's home. So I wouldn't know why somebody will be thinking of removing the entire prostate just for BPH, where we know that even if the person eventually develops a BPH, that patient will do well with a TURP if the person doesn't like medications. Now, to give orchidectomy because you're preventing BPH is not fair. It's not. Because once you have offered orchidectomy, either by medical means or by surgical means, you have removed testosterone, and all the benefits of testosterone in the individual goes. Libido is lost, sexual activity completely gone. Even if there is anything, it will be very minimal. Osteoporosis comes in, abnormal fat deposition coming, insulin dependent diabetes coming. You've really not helped that person because you're pursuing BPH that can easily be sorted out with a TURP should it develop. Now, the species of cassava, I must tell you that, yes, there may be things in the food we eat, many of which we do not even know. But recently, I came across a man who was having features of things we couldn't explain medically until we started asking questions. The wife was complaining that the man had some abnormal behavior and so on and so forth. Along the line, we realized the man, in trying to prevent prostate cancer or in trying to lower his PSA, started boiling cassava and eating it as if it's yam, and said he was advised to be doing that, or that he saw that in the internet or something. He wasn't sure of the species he was eating. I remember that there is a species of cassava that could be boiled. I remember my parents saying that during the Nigeria-Biafra war, that something like that was around for them to eat. They would just uproot the thing. 3 months after planting it, it has grown something for them. Uproot it, peel it, boil it, eat it. But I'm not sure that species in our southeast is still available. So when this man said he was eating cassava, I was worried. It became the regular species that we know has a lot of cyanide that the man was boiling and eating like yam with oil. I explained to them that that may be the reason for his abnormal behavior. Now, after the explanation, gave them what to do, I didn't see them again. So apparently, I didn't do well at trying to bring them out of that practice. So I don't know, this idea of species of cassava, it really needs to be important which species, and that needs to be communicated appropriately. And whether that works or not remains to be proven. Number of ejaculations have nothing to do with BPH. If there's anything at all, it may be with CA prostate, but not BPH. So it has nothing whatsoever to do with whether somebody developed a benign prostate or not. If he has any benefits, it will be with development of a malignant prostate. Then the other one, you said injections. Well, I think a once a day drug is a very good medication for somebody to take. Remember what I said about quality of life. If this person does not have significant disturbance in his quality of life, giving him medication is a waste of your time. He will not comply. And that's what will make him say, I took it today, I'll take it again next 3 weeks. He doesn't have a problem. So he may not have needed that medication in the first instance. So that needs to guide us. If somebody is not satisfied with the symptoms he's having, or somebody is unhappy, he will take medication. And if that medication makes him better, he will continue to take the medication, except he feels the medication had cured him, which needs to be communicated that the medication does not cure the enlargement. It only helps you urinate better. And any moment you stopped taking the medication, urination becomes difficult.
Okay, sir. Thank you, sir. Let me quickly run through some of other questions we have in the comment box so that I can respond to them before we wrap up, sir.
Okay.
I have this question. Is there any significant improvement with Flowell and any of those supplements like the saw palmetto you mentioned? That's one.
Is there any significant improvement in what?
With Flowell. Flowell is our own brand.
Okay. That's compared to the other one.
No, I think maybe the person is asking when you take the combinations, if there's any significant combining Flowell and any of the supplements like the saw palmetto.
Okay.
Then there's also another question. For falsely raised PSA, how long before PSA is repeated?
Before PSA is repeated, okay.
Yeah. That one is coming from Dr. Samuel David. Then there's also another question. At what stage should one be sent for biopsy?
Okay.
Then there's also another question. What guides you on when to use only Tamsulosin and when to use the combination Tamsulosin and Dutasteride?
Okay.
Then there's also another one. Can a patient be cancer-free from prostate cancer if diagnosis and treatment is initiated early?
What's that diagnosis and treatment for BPH?
No, he said, can a patient be cancer-free?
Yes.
In answer, if diagnosis and treatment is initiated early.
Is it diagnosis and treatment for cancer or diagnosis and treatment of BPH? You don't know.
I guess maybe I don't know the way I'm just reading what okay. Then he now said, another one says, some patients do well with the drugs initially, but after a few years, they develop urinary retention, placing the person on catheter, especially when they refuse surgery, could be a way of just temporarily helping them. There are now endoscopy and pinhole surgery. How cost effective is this, sir? That's somebody after using a product after a while now comes back with urinary retention.
That is definite now. You know, I've said it doesn't prevent the prostate from growing. And from this study we have here, when you're using Tamsulosin alone, the risk that the person can still have an acute retention is high. Look at the proportion that developed acute retention over time. It continued to increase. In short, by the 48th month for this study, virtually 90% of those who were on Tamsulosin alone had an acute retention. So,
Okay.
but with the combination using Tamsulosin and Dutasteride, it was, by that 48 months, it was about 30%. Not even up to that. It was about that, it was less than that. Less than 10% had an acute retention. Okay, no, this is not 90%, it's from 80. So 20% had an acute retention with Tamsulosin alone. But here, less than 9% had an acute retention.
Okay, there's also this one. I don't know if you can maybe respond to it. They said, what can
okay.
Go ahead, sir.
No, go ahead. Let me have it. Then I'll start from the beginning.
Okay. Okay, I think I said this. I've mentioned what guides you on when to use only Tamsulosin and when to use the combination.
Yes, you've said that.
You can just go ahead and respond, sir.
Okay, thank you very much, sir. So, well, Flow Well is just Tamsulosin, but Flow Well Plus is Tamsulosin plus Dutasteride. So if you're using just Flow Well, it still has this problem of tachyphylaxis that is seen with Tamsulosin alone. And the risk that many more people would have had an acute retention, even while they're on the drug, is high. So Palmetto, I've told you that for the sake of therapy, please, at our level, let's not prescribe that. If they tell you they are taking that, fine, allow them continue. Don't discourage that. But at our level now, please, let us not prescribe the supplements alone. No. If you want to give somebody supplements, it's just like you have given a treatment and you're giving vitamins to support the treatment. No problem. Don't rely on that supplement to give you any meaningful benefits. No. So if somebody is taking Flow Well and you added saw palmetto derivatives, no problem. But please don't attribute any benefit of that therapy to the supplements, because they may not be the ones giving that benefit. The alpha-1 blocker you're giving is the reason for the benefit. And to quickly say that alpha-1 blocker alone is not adequate in present-day therapy of BPH, except for those who have very mild symptoms. Except for those who have very mild symptoms. And such persons may also not really require treatment. Now, if you're giving it, it may give benefits weeks, months, but you're sure that very likely this person will come down with an acute retention over time. Always use the combination therapy. You're better off with that. When the PSA is falsely raised, what I want to understand is that the PSA is raised, you have done a biopsy, and it comes out benign. Then that biopsy will have to be looked at again, depending on the value of the PSA, how raised it is. If the biopsy was done with digital guidance, without ultrasound guidance, you may need to do an ultrasound-guided biopsy. If that ultrasound-guided biopsy comes back and says negative, take it for what it is and treat the person as BPH. Then monitor that PSA, maybe every 6 months, repeat the PSA. If it begins to show rise again, there may still be need to biopsy again. But if it remains stable, you may not need to further bother yourself again. But abnormal PSA is a difficult thing to manage, even globally, because the patient will be worried. Is there anything wrong with me? The doctor will be worried. Am I missing something here? Nobody is at home. Nobody is relaxed, simply because PSA is on the high side and the biopsy is saying there is no cancer. You can't treat him as cancer and you are not sleeping with your 2 eyes closed because the PSA is high. There are some things that can be done, including high-tech biopsies that we'll call conformal biopsies using, apart from ultrasound, using magnetic resonance imaging or using CT scan. But these are high-tech biopsies, simply to make sure that you biopsy any area that looks suspicious. But for us at this, in our practice now, ultrasound guided biopsy, if it is done appropriately and it tells you that there is no cancer here, you monitor the PSA probably every 6 months. Repeat the biopsy if there is rising PSA, and then take it from there. I've said that Tamsulosin with combination is better instead of Tamsulosin with Dutasteride, instead of just Tamsulosin alone. Any patients on the medication for BPH can still develop cancer. You're not cancer-free. Any patient who has done surgery for BPH can still develop cancer if the person has risk for cancer. Reason is that the surgery for BPH, the pinhole surgery or the endoscopic surgery for BPH does not remove the entire prostate. It only removes that part of the prostate that is obstructing urination, leaving behind a periphery that we'll call the peripheral zone of that prostate, still intact. And the truth is that it is in that periphery that most cancers start. It's in that peripheral zone that most cancers start. So they are not, BPH surgery does not reduce the risk for cancer. Does not. Okay. I don't know if there's anything I needed to point out. Thank you.
Okay, let me take this last question from Dr. Happiness. She's asking, what's the reason for constant waist pain in patients who present with BPH?
BPH does not give waist pain. There's no connection between BPH and waist pain. Once you have a patient who has symptoms suggestive of prostate enlargement and the person has waist pain, you must exclude cancer from that prostate. Otherwise, two things are happening. If it remains BPH, it means the waist pain is from possibly lumbar spondylosis. They are elderly, so they can also have spondylosis. If the prostate is not malignant, for instance, you do a PSA, it is low within normal range. Transrectal ultrasound says nothing suspicious of cancer here. Your examination, rectal examination, says nothing suspicious of cancer here. And low back pain is a major challenge. You do X-ray of that low back, there's nothing suggestive of metastasis. You do CT scan of that low back, there's nothing suggestive of metastasis. It can't be prostate cancer. It means he has a BPH and very likely has spondylosis as well. And there's somebody that asked about when do you refer. Actually, somebody on medical therapy should be referred for surgical therapy when, one, he is no longer responding to the medical therapy. How do you know? His IPSS is increasing. His quality of life is getting worse. He may develop post-void residual urine, or he may develop straightforward acute retention even while on that medication, or he may bleed even while on that medication. Any of these things means refer for surgical management. Putting a catheter on someone and continuing to give the person medical treatment while on catheter is inappropriate. Because the aim of the medical therapy is to allow urination. Catheter is already there, allowing urination. So there's no reason to give somebody medical therapy while on catheter. Except you're planning to remove the catheter and try him again. And if you've done that once, you shouldn't do that more than once. If somebody is tried on catheter is removed and is tried without catheter while on medical therapy, and he has another retention, there is no reason to try it again. No reason whatsoever. If the patient is forcing you to, tell him it is inappropriate. Such a person should go for the TURP or any of the surgical procedures. So that should be sorted out. Medical therapy should be stopped. Thank you.
Uncle, how many do we have?
Okay, I think we've taken basically most of the questions raised. I don't know if there's any other person that has any question that we've not taken, so that we can take it and wrap up. We'll spend quite some time here.
Or Oluchi. Tell kids to go to the house and bring 3 tomorrow.
Any question?
So call mommy to come. How much? 10,000.
Yes. Hi.
Okay.
Oluchi.
Can I go ahead?
You can go ahead, sir.
Okay, thank you, Dr. Nnabugwu, for this lecture. My name is Ike Okeke. I'm a pharmacist practicing in the United States. So I appreciate your lecture, and I appreciate the fact, number one, that you're now encouraging combination therapy as a first line of action for BPH. I think it is usually before the doctors will wait until the prostrate size is.
I can't hear you.
Okay, sorry, my phone is acting up. So my question is on, I want you to clarify on the pain, because a lot of time patients with BPH, we go to their primary care doctor complaining about back pain. And sometimes it could be cancerous, it could be just a prostrate cancer masquerading as BPH. So what should their primary care doctors do when they have this issue of back pain and BPH to rule out prostrate cancer, causing deletion of calcium in the bones and causing spinal problem? So that is my question.
A question or a comment?
It's a question. How?
Let me get the question. I didn't get it.
Okay. Okay. The question is, when this patient go to their primary care doctors with back pain and BPH, what will they advise the primary care doctors to do to make sure that these patients are not, it's not just regular back pain, that is not prostrate cancer?
Yeah.
So that's my question. To comment on that.
That's wonderful. I think I alluded to that when the other question was read. When someone has in brackets BPH and then low backache, I want to put that BPH in parentheses because the diagnosis of BPH is a diagnosis of exclusion. I need to say it here. That's what it is, even though we don't seem to appreciate it. If a man comes with symptoms of lower urinary tract symptoms, and we think that this man has significant bladder outlet obstruction, we begin to look for possible causes of bladder outlet obstruction in this man. If we do not find any, And all we are left with is the fact that the man's prostate is enlarging or enlarged. We'll simply conclude that the prostate is the reason for that. But the truth is that that prostate may also not be the reason for that, even though it's enlarged. Because the person may have some other bladder dysfunction in the process of an enlarged or an enlarging prostate. And that's why sometimes you may even end up treating someone surgically for enlarged benign prostate and you don't get the benefits you think you will get. Okay, now, BPH diagnosis is mostly a diagnosis of exclusion. By that, I mean you have excluded all the other possible reasons why that person could be having that symptom before you then say it is BPH. And because we do not use histology diagnosis for BPH, especially when we are treating medically, there's usually no histology diagnosis. That still buttresses the fact that we are treating it as exclusion. We have excluded all the other possible things and we are now saying it has to be BPH, so let's treat as BPH. The implication is this: once somebody has something else that is not in keeping with BPH, please explore that thing. Don't attribute that thing to BPH. Because you did not confirm BPH before you started treating BPH. All you did was that you excluded all the other possibilities and left yourself with BPH alone, and then you started treating as BPH. So any other thing coming up that does not fit into BPH, please explore that thing and address that matter. So for this low backache, for someone who had been receiving treatment for BPH, please explore that. By the time you repeat the PSA, repeat the transrectal ultrasound in these patients, like I said, those things should be repeated even when you're treating medically. Those things should be repeated so that the person is guided. Now, once you've repeated and they are still in the BPH range, in addition to repeating, you will also evaluate that lower back radiologically. Lumbosacral X-ray, CT scan should be the minimum. If needed, MRI. And with this information, even in the advanced communities, the scans, the radioisotope scans, with this, you arm yourself with more information to either biopsy that prostate or to continue to treat it as BPH, knowing very well that nothing, the thing happening at the back has nothing to do with the prostate. In that case, you would have identified the problem with the back. I don't know if I helped. The important thing, summary of it is this. Once you are treating, any person who is treating BPH is treating BPH because there is nothing else we could point at as the reason why that problem is there. Any moment we have any other thing to point at, BPH drops, doesn't get emphasized anymore. I'll give you instances. Somebody may develop CVA, stroke, okay? And this is somebody who had been living his life, may have been carrying an enlarged prostate at the age of 60, 65 or thereabouts, minimal symptoms or no symptoms. He develops a CVA. Shortly after that CVA, he begins to experience urinary symptoms. If you overlook that CVA with its consequences and go and do a BPH procedure for this patient, you make his matter worse. You make his matter worse because he doesn't have BPH as his problem. the enlarged prostate he's carrying is a component of his aging, and is not really the reason why he's having the urinary symptoms. So these things guide us in taking decision. Once you're treating for BPH, please keep reevaluating the patient if you're treating medically. Keep reevaluating the patient. Whenever there is something that is not in keeping with BPH, please, BPH should be lowered and that new thing evaluated and excluded. Thank you.
All right, thank you so much, sir. We really appreciate. One last one from us. Somebody's asking for permission to share your slides.
Okay. You mean
Just to,
I should share it with you?
no. Well, maybe if you share
already
it,
have it.
Yeah, we can always get, just to get your permission that maybe from here we can actually give to whoever wants, any of the doctors that are in attendance.
Fine, you have my permission.
Thank you, sir. Okay, in the absence of any other question, we want to, on behalf of Superior Pharmaceuticals, thank you very much, Dr. Nnabugwu, for this well-delivered lecture. We really appreciate your time, and we just want to say a big thank you for obliging us this. Thank you so much, sir. And for the participants also, we are very glad to have you. And we also want to say a very big thank you for your time. Thank you, everyone.
Thank you, sir. And thank you, everyone.
Thank you, sir.
All right.